So this weekend, I met a gentleman during Health Talk, and he was 52 years old. He told me that he's on a blood thinner because he has atrial fibrillation. And he really said something that stayed with me. He said he felt kind of tied down to this medication and he didn't understand why he needed to take this for the rest of his life. And he wasn't really angry. He was just kind of tired and confused and just really exhausted with the thought of having to take this drug forever. And honestly, hearing him talk about this really reminded me of my dad. For anybody that's seen some of my other videos, I've talked about my dad and how he died of heart failure. And yes, heart failure is what was on his death certificate, but that, really underneath that, there's a lot of other things going on, confusion around medications and mistrust of the healthcare or distrust of the healthcare system, I should say. But he was on warfarin. And similar to this guy, I don't know that he quite fully understood the ramifications of not taking that medication appropriately. Now, this gentleman eventually had understood why he needed to be on this medication. We had a very candid conversation, and I think he walked away with a good sense of security, hopefully. But yeah, it's one of those things where it's like, I have to get my labs checked. I got to think about what I'm eating. I got to watch my heart rate. And there's just a lot of things that go along with it. And so I often wonder if navigating that just feels like so much, so people just decide not to do anything at all. And so I really want to take this video today and explain anticoagulants in a way that hopefully removes some fear and replaces it with understanding, because when you hear that you have to be on the medication for the rest of your life, I can only imagine how daunting that can feel. It can feel like you're tethered to it or weighed down by it. But with certain conditions, it's just a thing that is going to be most beneficial to help improve survival. Now, there are some conditions where we absolutely can take you off of medication, but oftentimes if you present it with certain conditions like a clot, we may want you to be on an anticoagulant for a little bit longer. So if you or someone that you love is on an anticoagulant, then this is definitely going to be the video for you. I'm going to talk about why you're taking it, how it works, what some risks are, benefits as well, and really how to use these safely. If you are new to my channel, my name is Dr. Wallace-Gay. I am a clinical pharmacist in the primary care setting. I'm also an associate professor teaching primarily medical students, but also pharmacy students. And here on my channel, my goal is to break things down in a way that makes it make sense when it comes to medications. I want you to be able to think, ask, and act like the CEO of your medications. When you walk into any doctor's visit, you should be able to ask the appropriate question and feel empowered to do so. And part of that empowerment often comes with understanding the why and the basis of certain medications. So let's jump into it and talk about why or what a blood thinner really is and why it matters. The first thing I want to say is that the name is misleading. These medications do not technically thin your blood. Your blood has kind of a built-in system, a safety system called the clotting cascade. So when you cut yourself, platelets rush in, those clotting factors activate a sequence of events, and there's something called fibrin that forms this kind of mesh, and then a clot seals that wound. So that's protective for your body. But when a clot forms inside a blood vessel where it shouldn't be, that can be dangerous. So we know that these clots can travel to the brain and cause a stroke. These clots can travel to the lungs and cause what we call a pulmonary embolism, or PE. They can block arteries, and that can cause a heart attack because now you can't get oxygen and blood to the heart. They can also form in the legs, which we refer to as a deep vein thrombosis, or DVT. And anticoagulants are going to slow down that clotting cascade so that your blood doesn't clot as easily if you're someone who has had an issue with clotting very easily in the past. Now, these medications don't dissolve clots. We have other medications for that, but they do prevent new ones from forming and keep existing ones from growing. So that is what these drugs do in a nutshell. Now, let's talk about certain medical conditions and why these can be dangerous. So first is atrial fibrillation. In atrial fibrillation, or AFib, the upper chambers of the heart kind of quiver instead of squeezing like they're supposed to. So we know that blood's not moving smoothly through the body. It often kind of swirls or pools, is what we tell people. The blood will pool there because it's not able to just flow seamlessly like it normally would. And when that blood pools, clots can form. And then that clot can leave the heart and go straight to the brain and cause all other kind of issues. And so that is why AFib increases your risk of stroke by up to 5 times as high as someone who doesn't have AFib. So even when someone says, I feel fine, why do I need this? It's because AFib strokes are often silent until they are catastrophic. There won't be a lot of preliminary signs before that stroke occurs and that blood clot forms and travels. So the medication is not going to help with any symptoms. It's specifically to help with prevention. If you have AFib, and there's a scale that we look at to help us know like how high of a risk you have of having a clot with AFib, but a lot of people meet that criteria. So if you meet that criteria, then we would go ahead and put you on one of our anticoagulants to help prevent your risk or greatly reduce your risk, because it's hard to say that we're going to completely prevent something from happening, but to greatly reduce your risk of having a stroke. Now, the other thing that can happen is the DVT or the PE. So a DVT is a clot in a deep vein, and it's usually the leg, but not always. And so some symptoms of this can be swelling in the lower extremities or wherever, but oftentimes it's the lower extremity or the lower limb, I should say. And that can sometimes be warm to the touch. It's usually on one side, not both sides. It can be painful. Sometimes the back of the leg is where we feel that the most. And if part of that clot breaks off, if there's a clot that forms there and part of that breaks off and travels, it can go to the lungs. And then there is what we call it a pulmonary embolism. And so in individuals who have a pulmonary embolism or PE, they have this sudden shortness of breath that's unusual for them. They may experience chest pain or rapid heart rate. And both of these can be life-threatening. So if you've ever had one, you're definitely at a higher risk of having another one. Or if you're in certain situations, like you're not able to ambulate, not able to get up and move around, if you have cancer during pregnancy, all of these things are what we call hypercoagulable, meaning you have a higher risk of your blood coagulating or clotting. And we might go ahead and recommend an anticoagulant in some of those cases. So depending on what's going on, an anticoagulant duration might be months or it could be lifelong. Again, it just really depends on the risk. And also, if you've already had an event, it depends on if that event was caused by something that we know is not going to be an issue moving forward. Like you were sitting for a really, really long flight. That is what provoked or led to blood pooling and then causing a clot. So then we may only put you on that drug for 3 months, 6 months, reevaluate, and then potentially have you come off of it. But again, if you have AFib, if you've had a DVT or a PE before, then you'll likely be on medication for lifelong. So I'm going to talk through some of the medications, and I'm going to be brief here, but if you have any questions, please drop them in the chat. If you're on one of these medications, drop it in the chat and let me know which one you're on, or your family member, how you're handling that. But we're first going to talk about warfarin. Warfarin's kind of one of my favorite drugs just because it's an oldie and goodie, but it's one of those, it's like it doesn't play very well with others. Warfarin specifically works by blocking vitamin K dependent clotting factors in the liver. So I talked about that clotting cascade. So when you get a cut or whatever, this cascade turns on and a clot ends up forming at the end of that to help protect you from just bleeding and bleeding and bleeding forever and ever. Some of those clotting factors depend on vitamin K in order for them to be developed or formed in the body. So they have to have vitamin K in order for them to be formed. And this is not something that you have to know, but just for completeness sake, those clotting factors are factors 2, 7, 9, and 10. So we have lots of clotting factors, but factors 2, 7, 9, and 10 are the ones that are driven by vitamin K. So warfarin is going to reduce their activation. Now, because the liver makes these clotting factors, your liver function matters. So if your liver is not functioning properly, that is something that we're going to have to adjust for or may have to switch you to a different medication. So they should be checking your liver function anytime you go in to be seen. Now, if you are someone who is dealing with long-term liver disease, or if you have a dependence on alcohol, or if you have some type of illness that could change your levels, then we might be very cautious about putting you on this medication as well. So warfarin, if you don't already know, it requires monitoring. And there's something called an international normalized ratio, or INR, that we check when individuals are on warfarin. Now, this spits out a number and tells us how long it takes your blood to clot compared to normal. Now, for most people, we want that number to be between 2 and 3. There are some exceptions to that. I won't go through all of the exceptions in this video, but there are some exceptions to that. But for most people, we want your INR to be between 2 and 3. If that number is too low, so less than 2, then your risk of having a clot is higher. That means your blood is thicker. And I caution with using those terminologies, but for simplicity's sake, that means your blood is going to clot faster, it's thicker. If your number is high, it's greater than 3, then that means your blood is thinner and your bleeding risk is higher. So we have to make sure that we're aiming for that sweet spot of 2 to 3 when it comes to the INR. Now, I mentioned that warfarin is kind of finicky. So specifically when it comes to diet, vitamin K is found in a lot of stuff. So if we're giving a medication that is preventing vitamin K because we want to reduce the clotting factors that are being formed, then we have to also make sure that we are not fueling the body with a bunch of extra vitamin K that could then lead to more clotting factors or, more of those clotting factors being formed. So some of the foods that we eat have vitamin K in them. And so a lot of patients will come in and say, oh, I can't eat green leafy vegetables, I can't eat salads because I'm on warfarin. And of course, that is not true, but what is true is that you have to be consistent. And I know that that can be difficult. So you have to try to consume about the same amount of vitamin K weekly. And so for some people, they're like, no, thank you. I'll just not do it at all. But vitamin K is mostly found in really dark green leafy vegetables like spinach, kale, broccoli, collard greens, things like that. But it's also in other things as well, weird stuff like mayonnaise and also cauliflower. And the amount of vitamin K in each of those varies. So it's in a lot of different stuff. There are online charts that you can download that will show you how much vitamin K is in different amounts of different foods. So like a cup of spinach contains this much vitamin K. And that way you could try to be consistent with it throughout your week, every week. So if you eat spinach every day, great. But you don't want to just stop eating it cold turkey because then that's going to affect your INR. And also, if you notice that you've made any changes in your diet, you went through Thanksgiving holiday and decided to have a serving of collards, then you will want to let your healthcare practitioner know that when they check your INR, because your number might be a little bit lower and they'll be like, what happened? And so you could just let them know that, oh, I had some collard greens the other day. Now, another thing to keep in mind with warfarin is that you are primarily going to see anything that you do when it comes to your diet or missing a dose within 2 days. So if you miss a dose today, I won't be able to see the effects of that missed dose until a couple of days from now. And similarly, if you come in like next week, then I won't even be able to tell that you missed that dose a week ago. We've kind of missed that window of knowing what that missed dose did to your INR. So just know that whatever happens, it's usually about a 2 to 3 day time frame of like, I ate collard greens. I'll see the effects of what these collard greens did to my INR in 2 to 3 days. Or I missed a dose. I'll see the effects of that missed dose in 2 to 3 days. You won't see it show up that day or even the next day. Now, warfarin also interacts with a lot of medications. So if you're ever started on an antibiotic or an antifungal, or there's certain supplements as well, then you want to let your healthcare practitioner know, or just be cautious before you start it. It's hard to not start your antibiotic. So you just need to make sure that they know that you're on warfarin before they give you an antibiotic. Perhaps you've gone to your dental office. Make sure that they have your full medication list. And also just be very cautious about which supplements you take over the counter because they can sometimes interact with the warfarin and cause it to leave your body too quickly or hang around too long. And if the medication leaves your body too quickly, then you're at risk for having a clot. If the medication stays around in your body too long, then you're at risk of bleeding too much. So we don't want either of those extremes. You also have to be cautious about drinking alcohol. I mentioned that just because it affects the liver, and that's where these clotting factors are formed. And then also be cautious about using NSAIDs like ibuprofen, naproxen, which is things like Motrin and Aleve. Just be careful with those because those do thin the blood a little bit as well and also compromise the lining of your stomach. And we don't want you to have a stomach bleed because you're taking NSAIDs very often and also taking warfarin. So warfarin's older. It requires a lot of work, but communication is going to be critical when it comes to this. It's very affordable, so people are on it. It's proven. We know that it works. And right now, it's the only safe option that we have for individuals who have mechanical heart valves. We know that those valves tend to, any device in the body tends to have a risk of clots forming on that. So we would need to give something like warfarin right now for mechanical heart valves. We can't give any of the other agents. Now, quickly, I'm going to talk about the other anticoagulants, which we call direct oral anticoagulants. So instead of them blocking vitamin K, they specifically target one clotting factor. So medications like Apixaban and Rivaroxaban, or this is Eliquis and Xarelto, they specifically target factor 10A, and they block it. So they block or inhibit factor 10A from going forward and leading to the formation of clots. And then we've got something called Pradaxa or Dabigatran, which is a direct thrombin blocker or inhibitor. So it blocks thrombin, which then reduces the risk of having a clot. So within that clotting cascade, it will block the thrombin component of it. So these medications work very quickly, whereas warfarin, it takes a couple of days to start working. But these work really quickly. They have a very predictable dosing, so we don't have to modify the dose very much. They don't require routine INR monitoring or anything like that. But they do rely a little bit more heavily on knowing what your kidney function is, because the kidneys are really important for clearing these drugs out of the body. So making sure that you're getting your kidney levels checked very often is important. Now, one last thing that I wanted to mention with warfarin is that sometimes you can be on multiple doses. So like with the newer agents, Xarelto, Apixaban, you're going to have your dose, and that's going to be your dose every day, all day. With warfarin, depending on what your INR levels are, they might have you taking 5 milligrams on one day, 7.5 on another day. And that means that you have to take a tablet and a half on the 7.5 days and one tablet on the 5. It's confusing to even say out loud. So I know it can be confusing for patients. And we usually send you home with a little calendar that outlines all of that so that it can be as clear as possible. One thing that I don't like to see and that I educate the students that I talk to about often is trying to keep someone on their same tablet strength as you're adjusting the dose. So as best as possible, advocate and don't try not to allow them to send you home with a 2 milligram and a 5 milligram and a 7.5 milligram tablet or whatever, so that you can just not get those mixed up. Now, they are different colors, so that's helpful, but I mean, it can just be very confusing to have a bunch of different doses at home, and then the dose is changing often, and it just gets really confusing. So just keep that in mind. Now, missed doses. I want to talk about this because this is really critical, really important. Warfarin has a long half-life. So if you miss a dose, it usually doesn't immediately cause an issue. You want to take it consistently, but if you miss a dose, it lingers in the body for a few days. That's not the case with the other medications like Xarelto and Apixaban. They wear off a lot faster. They're out of the body a lot quicker. So if you miss one dose or 2 doses, this can significantly increase your risk of clot and increase your risk of having a stroke. So if you miss a dose, you want to make sure that you follow the instructions on the guide. Usually you don't want to double up unless directed, but call your pharmacist or your healthcare practitioner, physician, nurse practitioner, whomever you see, just to make sure that you are doing the right thing. Your nurse can also usually answer those questions for you in the portal. So you just want to make sure that you're doing the right thing if you miss a dose. You also don't want to just stop it suddenly. So that's kind of the same as missing a dose, but some people decide they don't want to take it anymore. And so then they just stop taking it. Significantly going to increase your risk of having a stroke. So please don't do this. This is not the type of medication that you can just casually pause and put the brakes on. If you go out in town and you leave your pill bottle, you need to be calling somebody to get you some emergency supply of your Xarelto or Apixaban. So on the other side of clotting is bleeding, right? So we have to balance it. So bleeding is going to be a risk. And because we are trying to reduce your risk of clot, we are going to slightly increase your bleed risk. So you might see some minor bruising a little bit easier, maybe some mild nosebleed. But if you ever see black stools, if you're vomiting blood, if you have a very severe headache, especially after a fall or a head bump, any uncontrolled bleeding, those are things that you definitely need to contact somebody about immediately, because you may be over anticoagulated. And we do have reversal agents that will stop that anticoagulant in its tracks and reverse if you've accidentally taken an extra pill or something has happened that has caused you to be over anticoagulated. A big thing to note is that warfarin is cheap. The DOACs, although they're a little bit less expensive now, they can still be more expensive for some. So if cost is an issue, you can always ask about patient assistance programs. There's usually something out there that can be implemented for you to help you pay for it. You can also ask your pharmacist to check for alternatives. Sometimes your provider will call in one drug, like Xarelto, for example, and your insurance company doesn't cover Xarelto, but they do cover Eliquis. And we just need to look that up, and they may not cover both of them. So sometimes we can look for alternatives in that way. And also you might ask if warfarin is appropriate in your situation. Maybe it's not ideal for you to travel to the clinic. It's really far from your house. And you're not able to do that every other week or monthly even. But whatever the situation is, you just never want to stop these medications silently without telling anyone, because the risk can be fatal. As I kind of bring it back to the guy that I talked to, and we really talked about understanding why he's taking something long term. I think that once you understand why, it feels like less of a chain. And he was like, yeah, I get it. He started to feel like it was more of a protection, and that being on this blood thinner did not mean that he was less than, and it did not have any reflection on how well he took care of himself. He had been no idea where it's coming from or what's causing it. So, he's treating himself, protecting himself with the best medications that we know possible right now, and just reducing his risk of something that could be catastrophic. So the goal here is not dependence. The goal is prevention. We want to prevent stroke, prevent heart attack, prevent blood clots, PE or DVT. And if you need 5 questions to ask your provider, we'll end on this. Number 1, you want to ask, why was this chosen for me? Why are you giving me this specific one out of the other ones that could be given? What is my stroke risk without it? Do I have to have it? And oftentimes I will tell you the answer is going to be yes, but it's good for you to know why. And you want to know what to do if you miss a dose, because each of the medications is slightly different. So what do I do if I miss a dose? What bleeding signs require urgent care? I already talked about some of those, but it'll be good to hear it from their perspective. How often should we reassess? So when do you need to be coming back for labs, and which labs do you need to get? In this situation, when you're talking about your heart bleeding, you deserve all of the clarity that you can get, and to be able to go into this without any fear. Hopefully this was helpful. Please like and subscribe, and I'll see you in the next video.